Hello everyone, this is Kendra Mickens, and I'm presenting my graduate project on the utilization of simulation for early detection of sepsis. When you look at my project description, you can see that my project sought to incorporate simulation use as a means of educating nurses and allowing facilitation of learning. Well, when we look at simulation, it has actually evolved over the years, and it was originally used with pilots who were actually able to practice flying blindly. Of course, this allowed them to have a much safer way of learning how to do that. And for us in the medical field, it has also far progressed past good old Rescue Annie that they used in the 1960s with CPR. And then we have even come past SimMan, who was created in 2000. When we look at simulation, it has been used in healthcare to improve skills of healthcare workers in performing activities such as CPR, working in teams, and delivering anesthesia. Sepsis, while we all know the condition, continues to go undetected with serious mortality consequences, with up to 1,000 people impacted per 100,000 people with severe sepsis. And when we look at it, nurses are considered vital to detecting sepsis, early, but nurses must be educated on the early signs and symptoms of sepsis, risk factors, and organized methods for detection. When we look at my scenario, I created a scenario for simulation revolving around a woman named Thelma Rogers. The Thelma Rogers scenario focused on the patient meeting the systemic inflammatory response syndrome criteria, also known as SIRS. And for it to be sepsis, she met at least two of that criteria plus infection, with her source being pneumonia. When we look at it, a simulation was created based on the patient that was septic, but not yet in severe sepsis or in septic shock, which, as my project unfolds, we'll see nurses are actually excellent at identifying septic shock. The simulation included objectives, background on the patient for the simulation, vital signs, system assessment findings, lab values, chest x-ray and a radiology report, and teaching points. I served as the voice of the patient and the doctor throughout the simulation and led the briefing for simulation as well. Both a pre and post survey were completed by the learners of my simulation. When we look at project learning objectives, you can see that it went over the initiation of the nursing process, analyzation of data, prioritization of data collected, and communication through utilization of SBAR, which is, of course, situation, background, assessment, and recommendations, identification of signs and symptoms of sepsis in particular, and then ability to function as a team member. So when we look at it, we had them initiate the nursing process through interviewing and completion of a focused physical assessment. They were to analyze data and then also evaluate laboratory values and deduct correlation to the assessment findings. We wanted them to prioritize and organize data to effectively communicate to the members of their healthcare team through the utilization, of SBAR. And then we also wanted them to identify signs and symptoms of sepsis and illustrate knowledge of appropriate actions through nursing interventions implemented. And then function also as a team, because in our simulation, they typically went in 3 or 4 at a time. So that it was a group simulation with a team aspect also as an objective for them to focus on. When we look at my teaching points actually served around code sepsis, which at the facility for which my learners were actually practicing nurses, they have a code sepsis that actually outlines ways to better identify sepsis and then what's the next plan to institute. We went over the SIRS criteria: sepsis, severe sepsis, MODS, which you'll find out is a multiple organ dysfunction syndrome, and then septic shock criteria, which we actually went into great detail about the differences of each. With SIRS including things such as a temperature of greater than 101.3, a heart rate greater than 90, respiratory rate above 20, and then a white count of greater than 12,000. When we look at sepsis, a person typically meets at least 2 SIRS criteria plus the source of an infection. And for the focus of my simulation, that source of infection was pneumonia. When we look at severe sepsis criteria, of course, they're going to meet everything for sepsis, but also have things like organ dysfunction, lactic acidosis, abrupt change in mental status, difficulty breathing. And then, of course, multi-organ dysfunction syndrome is pretty much exactly what it sounds like, in which there's going to be severe sepsis where two or more organs experience dysfunction. And, of course, the dreaded septic shock, in which we typically see all these signs and symptoms, plus hypotension, and not just hypotension, but hypotension that does not respond to fluid resuscitation. When we look at the facility, program, and target population of my graduate project, the facility was Carolina Simulation Center, which is actually a duly accredited facility. It is accredited by both the American College of Surgeons as a Level 1 education institute, as well as the Society for Simulation Healthcare Accredited Simulation Center, with assessment, research, and teaching and education. When we look at the Simulation Center itself, it actually has various functions and services that it offers, not only to nursing students and practicing nurses, but residents and doctors, as well as people in the community who can actually contact the Simulation Center and reach out for additional services, where the education members and also the med technologists will come out to different facilities. They will bring the mannequins that they have, along with the computerized laptops, in order to facilitate simulations on campus. When we look at the program that was impacted by my project, it was actually a program entitled Advance, which is a nurse residency program at Carolinas Medical Center. When we look at the Advance program, it is actually held over a 10-month period for a time that offers then 36 hours of professional core curriculum with 12 hours of built-in simulation, with also offerings of formal classes and a preceptor training. When we look at my target population, it is actually those advanced nurses. The advanced nurses are typically nurses that are new in transitioning to practice in the areas of medical surgical units, the emergency department, and then also perioperative nursing. When we look at this target population, and also a focus on us having a earlier identification of sepsis, this was felt to be a really good group. When we look at med-surg nurses, we know that a lot of times they do receive those post-operative patients who are at risk for developing an infection and then becoming septic. When those patients are then released and go home, we know that, again, sometimes people do develop sepsis at home and then will typically re-enter the hospital system through the emergency department. So, of course, it is very important for the emergency department to also be able to detect sepsis. With them, there is also the ability for them to actually start instituting things like the sepsis bundles, which have been outlined by the Surviving Sepsis campaign in 2012, where we can get earlier interventions, which can better decrease mortality rates, in which they can, based on the criteria, go ahead and start collection of blood sampling, so that we can actually see blood culture results at a sooner time frame, so that we can then actually treat the appropriate organism sooner, as opposed to having to rely on broad spectrum antibiotics. And then, of course, perioperative nursing have the ability, if they understand the impact that they have on patients developing sepsis, if they do not use aseptic technique and sterile technique when needed, understanding that they could then increase the patient's likelihood of developing sepsis is highly important. So we found and felt that this group would be ideal for instituting a simulation that would be focused again on the early detection of sepsis. When we look at the background, sepsis mortality rates can be as high as 15 to 30%, with an increase as high as 30 to 60% if the person develops severe sepsis. So identification and creation of a process for early identification has been associated with improvements in those mortality rates. When we look at a study by Sergakis, Clutter, Holthus, Naken-Nelms, Rogrig, and Wilcox, it has been shown that simulation can be used to improve not only the skills, but the confidence, enhance teamwork, and improve communication among healthcare workers. The confidence noted in simulation has been noted to extend not only to the individual, but their team members as well. In another study, it was also noted that there were positive outcomes when simulation was used to address emergency situations, as have been viewed favorably by both the educators seeking ways to improve outcomes through the education of the staff. When we look at the process or method that was implemented for this project, a simulation was developed. We did create a pre and post survey. And when I say we, I created it, but I did have feedback from my preceptor to look over it and give final approval before anything was instituted to the learners. Simulation was conducted along with a debriefing that was facilitated by myself. And then I was able to actually analyze the survey results through SurveyMonkey, which was the database that the Simulation Center uses. When we look at the individual's timeline and permission, the individuals that were involved outside of myself were my preceptor, the medical technologist that actually took over all of the laptop work for actually running SimMan 3G, which is who we utilize for this particular simulation. So for any changes in the vital signs, any changes with bringing up the lab work, per my direction, I had a medical technologist that was able to do all of the computerized work, so to speak, while I acted then as the doctor and the patient during the simulation. And then, of course, we had our learners that were involved in the simulation. The timeline for the simulation was approximately 15 minutes, just to allow them to interact with the mannequin, do an assessment, again, work on all of those objectives with collection of data, interpretation through the nursing process, actually communicating with me, the patient, as well as me, the doctor, and then working as a collaborative team to see if they could then identify what was going on with the patient. And within that time frame, they were able to identify that the patient was suffering from pneumonia, but we did not quite make it to the point of them identifying that the patient actually was septic. I did not need any additional permissions for this particular project, as it was my task to actually update and change one of the areas that the simulation educators actually goes over with the advanced learners, which before it was a septic shock scenario, and I was able to create a brand new scenario that actually focused on a person who was in early sepsis, not quite as obvious, not quite as sick, but of course, research has shown that that is when we want to identify patients, not once they are already in severe sepsis or septic shock, but again, identifying it early when it's not quite as obvious. And again, I had the opportunity to create that. And since it was a new education and not actually a new program, we did not need any additional permissions. And again, it wasn't an actual experiment on anyone where I needed to receive any consents. When we look at the actual evaluation part of my project, I do have some pre-survey results. And this was actually one of the questions that was on the pre-survey that was actually focused on SIRS identification. When you look at this, you can see we were looking for between an 18-year-old who had a productive cough, a heart rate of 80, respirations of 20, a tempo of 99.1, a 25-year-old male with an indwelling catheter, heart rate of 95, respirations of 24, tempo 100.6, and then a 58-year-old postoperative female patient, heart rate of 90, respirations of 18, tempo 100.2, and then a 78-year-old male with a decreased level of consciousness, heart rate of 76, respirations of 14, tempo 102.1. We were looking to see if they could identify which one of these particular patients actually fell within the SIRS criteria, where typically we would see at least 2 abnormalities present. For the simulation that they were participating in with Thelma Rogers, she actually met all of the SIRS criteria with a pulse of 98, respirations of 24, and a temperature of 101.6. And in her lab results, her white count was 13.5. This question was again presented actually on both the pre and post survey. And then as the group of learners actually looked at it, and this was both the active learners who were in the simulation and the passive learners who were watching the simulation, they all felt collectively that Thelma Rogers, with those vitals in that lab work, was actually only about moderately sick on a scale of 1 to 10. Most said less than 5. And actually, none prior to our debriefing would have identified her as septic. When we look at the evaluation outcome, as previously mentioned, none of the learners were actually able to identify that the patient met the SIRS criteria or that she was septic. During the simulations, the learners were able to identify that the patient had pneumonia, but never made the connection to the fact that the patient was septic. During debriefing, learners were able to discuss what they did well, and the passive learners observing were also able to provide their feedback. It was learned that the nurses were able to identify septic shock, but were less prepared to identify the signs and symptoms of early sepsis. Learners were not aware of the badge card that is available at their facility that outlines code shock, which was reviewed and actually provided to them during the debriefing. The debriefing actually highlighted the objectives of the simulation that they did meet, as well as a learning conversation that was facilitated regarding SIRS, sepsis, severe sepsis, MODS, and the septic shock, which were again in the teaching points. When you look at this actual result here of their pre-survey results, you can actually see for that question on which one of these patients met the SIRS criteria. Actually, in the pre-survey, before anyone actually participated, no one actually picked the right patient, who was actually patient B. And then we will actually look at the post-surveys to see if there was any improvement. And we actually have success. Not quite the success I would like, but some learning I will take over no learning at all. And if you look at this, we can see that 3 learners after the debriefing and going through the simulation were able to accurately identify which one of the patients actually met the SIRS criteria, which was again the 25-year-old. When we look at how did it go overall, after the simulation session, overall we did receive positive feedback. When we were looking at the evaluation, again, I think it was important to know that with the inability to identify that the patient was in SIRS, it was very difficult to then actually realize that they had a septic patient. Again, in looking at the success, we were very happy that we were able to prove that there was evidence of learning based off of the simulation and the debriefing. Again, there were overall positive feedback from the learners on how they felt the simulation went, with at least 75% reporting that they strongly agreed that they were better able to recognize the symptoms. And when they looked at their confidence in their role, at least 87.5% felt like they were more confident in their role, which is, again, what we wanted, especially as new nurses, to have more confidence and to have better skills and feel like they're better equipped to assess their patients. There were some barriers. When we look at the barriers, I list things such as no control over the schedule for advance, no data available on which learners arrive for simulation. The timing of the simulation was not always optimal, and that is actually for the learners. And then some learners come with previously poor experience in simulations. So when we look at the actual advanced schedule, it's not created based off of the simulation schedule. So sometimes they're just back to back to back with little time for decompression, or they can be on a time crunch. We don't always get an update of the skill mix of the nurses coming in. We may know what unit they're from, but most often we just know what hospital and not the unit. With more information, it is felt we could provide them a better learning experience and be better prepared to have some of the things that they may see on their unit. Regarding the timing of the simulation, again, not being optimal, some of the learners would be getting off work to come to simulations. Some, it would be their day off, but most often, most of them were coming from working straight into the simulation. As the learners are new nurses, most have had experience with high fidelity simulation in nursing school. And this is speaking to the previously poor experiences. This was something that we actually learned during the orientation process, which is actually what I'm also listing as one of the best means we had of overcoming some of these barriers. At the Carolina Simulation Center, they actually do an excellent orientation process where all of the learners that are coming through the advanced residency program are introduced to the simulation educators, and I was a part of that process. They're able to talk about their experience, introduce themselves, get to know each other that are coming in as new nurses, although they're not always in the same orientation group. And again, they're able to share what their previous experience has been with simulation, so that, again, the simulation educators have an opportunity to kind of troubleshoot, kind of alleviate some of their concerns, and let them know it's not quite the same experience that some of them have had in nursing school. While the Simulation Center does record the actual simulation as it's going on, it's not for the learners who are participating to have to watch themselves. It is more of a means to actually stream the simulation to the passive learners who are in another room, as opposed to kind of picking apart the learners for anything that they possibly would change. So again, the simulation educators are big on the psychological safety of all the learners, which from what I could see from seeing some of the learners who had apprehension at their orientation come away very pleased with the simulation that was actually facilitated for them during the advanced program. When I look at the project alignment with outcomes, I do feel like my project did align with a lot of the outcomes for our graduate program. I had to do an extensive review of literature, not only to create my simulation, but to find a simulation that I felt would be fitting for my learners, and again met with an identified knowledge gap, which was already present, which was again sepsis. But in reviewing what the needs were of the hospital system and the new nurses coming in, we again found that it wasn't so much septic shock, but early signs of sepsis, which again, in doing my literature review, so that we had evidence-based practice, that is a nationwide and actual international issue. Also, I was able to get resources from the Mayo Foundation, as well as General Medical Sciences, or excuse me, the Institute of General Medical Sciences, in order to help formulate the basis for my simulation, which again had to be evidence-based practice. When we look at the data collected, I again collected data not only on the support of better education for nursing and sepsis, but the utilization of simulation to facilitate that learning. So again, my review of literature for evidence-based practice was actually not just on the improvement of nurses' education for better outcomes, but also the utilization of sepsis to facilitate that learning. I was able to take the lead on the revision and creation of a new simulation for the purpose of educating new nurses who again were transitioning practice. I was able to utilize up-to-date technology for both simulation programming, and was able to conduct a simulation again with good old SimMan 3G, which is pretty much a state-of-the-art mannequin. In supporting the push towards better education and sepsis identification, I was able to advocate for the policy and spread knowledge of its presence to new nurses so that the health of patients could be improved. And the standards regarding sepsis identification are current and in keeping with improvements that are being advocated to be seen on both a national and international basis, especially if we look at projects like Surviving Sepsis, which is a campaign that was started in 2012. Which actually extended the collaboration from national to an international community and level. During this process, I was able to explore more ways to incorporate simulation into the graduate nurse role. Nurse anesthetists, I saw frequenting the Simulation Center. They actually have their own surgical room that they spent the majority of their time in simulation. But I must admit, it did cause me to challenge if there are other ways that simulation could be used in an educator track. We talk about simulated patients for the learners, and I have thought about the idea of maybe simulated learners for a nurse educator, where we could be in the role of a mock clinical situation where our simulated learner would then have questions for the educator to respond to. Not to mention just being in the educator role as a graduate student of creating additional simulations, a lot again with also transitioning case studies into simulation, evaluation of those simulations, and most importantly, what I've learned with this project with simulations is the facilitation of the debriefing, where the majority of the education was learned. I was also afforded numerous opportunities to perform in the role of an educator, not only creating simulations, but programming simulations, facilitating both simulations and debriefings. And what I benefited from, of course, was collaborating with simulations with other simulation educators, especially my preceptor, where the focus was always on education. When we look at the impact on nursing in education and practice, which actually this project actually would impact both. It did provide education, but education with a goal of us improving the safety and outcomes for patients. So it supports utilization of simulation for facilitation of learning in healthcare professionals. Improved identification process for sepsis. It provided helpful code sepsis reminder for the employees. And it also had improved identification of sepsis for patient safety, which will hopefully improve the safety and outcomes and decrease those mortality rates. I hope you have enjoyed my presentation. You will see my references, and thank you for listening.